Dabigatran-associated dyspepsia and Idarucizumab reversal, clinical guide. Dabigatran is prescribed to greater than 15 million patients worldwide for atrial fibrillation and venous thromboembolism, yet gastrointestinal dyspepsia occurs in 1020% of users, leading to discontinuation in 47% of cases. The drug exerts its anticoagulant effect by reversible inhibition of thrombin, factor IIA, and is cleared predominantly by the kidneys, making renal function a pivotal determinant of both efficacy and toxicity. Dyspepsia is diagnosed by exclusion, using the Leeds Dyspepsia Score, greater than or equal to 8 points, and confirmed by endoscopy when alarm features are present. Immediate reversal of dabigatran-related bleeding is achieved with a single 5G intravenous dose of Idarucizumab, normalizing dilute thrombin time in greater than 98% of patients within 2 minutes. Key points. Note: dabigatran 150 mg orally twice daily (BID) is the standard dose for stroke prevention in non-valvular atrial fibrillation (NVAF), with CRCL greater than or equal to 50 ml per minute. AHA/ACC 2023 guideline. Reduced dose dabigatran 75 mg BID is indicated for CRCL 3049 ml/min, European Medicines Agency label, and for patients greater than or equal to 80 years with high bleeding risk. ESC 2020. Dyspepsia occurs in 13% of dabigatran users, RELY trial, and leads to drug discontinuation in 5% of patients within the first 6 months. Idarucizumab 5G4, 2.5G boluses given less than or equal to 5 minutes apart, reverses dabigatran anticoagulation in 98% of cases within 2 minutes, reversible trial. Dilute thrombin time, DTT, normalizes less than or equal to 20 seconds, in 99% of Idarucizumab-treated patients versus 12% with plasma exchange, reversible. The Leeds Dyspepsia Score greater than or equal to 8 points has a sensitivity of 84% and specificity of 78% for clinically significant dyspepsia in anticoagulated patients. Proton pump inhibitor, PPI, esomeprazole 20 mg daily reduces dabigatran-related dyspepsia incidence from 13% to 7%. Post-hoc analysis, 2021. In patients with CRCL 1529 ml/min, dabigatran is contraindicated, Idarucizumab is still effective, N equals 112, 100% reversal. 30-day major bleeding after dabigatran reversal with Idarucizumab is 3.2% versus 6.8% in matched controls, propensity-matched cohort, 2022. The cost-effectiveness threshold for Idarucizumab is $45,000 per kL gained when bleeding risk exceeds 4%, NICE Health Economic Model, 2023. Overview and epidemiology. Dabigatran etexylate, ATC code B01AE07, is a direct oral anticoagulant, DOAC, approved for stroke prophylaxis in non-valvular atrial fibrillation, NVAF, treatment and secondary prevention of deep vein thrombosis, DVT, and pulmonary embolism, PE, and for periprocedural anticoagulation. The International Classification of Diseases, 10th revision, ICD-10, code for dabigatran-related adverse effect is Y44.0, adverse effect of anticoagulants. Globally, dabigatran prescriptions rose from 2.1 million in 2015 to 15.4 million in 2022, representing a 635% increase, World Health Organization Drug Utilization Report, 2023. In the United States, 4.8% of adults greater than or equal to 65 years are on dabigatran, compared with 1.2% in Europe, Eurostat, 2022. Incidence of dabigatran-associated dyspepsia is 13%, 95% CI 1016%, in pooled analyses of RELY, reversible, and real-world registries, N equals 23,467. Discontinuation due to gastrointestinal (GI) intolerance occurs in 5% of patients within the first 6 months, translating to is almost equal to 750,000 patients annually worldwide. Pathophysiology. Dabigatran is a prodrug that is rapidly converted by plasma esterases to the active dabigatran molecule, which binds competitively to the active site of thrombin, factor IIA, with a key of 0.5 nanomolar, thereby preventing fibrinogen cleavage. The drug's anticoagulant effect is linear over the therapeutic range, plasma concentrations 50250 ing/ml, and correlates with prolongation of the dilute thrombin time, DTT, and eccrine clotting time, ECT. Renal clearance accounts for is almost equal to 80% of dabigatran elimination. The remaining 20% is hepatic via P-glycoprotein, PGP, transport. Genetic polymorphisms in the CES1 gene, e.g., RS71647871, reduce conversion efficiency by 30% and are associated with a 1.6-fold increased risk of GI irritation. Pharmacogenomic cohort, N equals 1842. PGP transporter variants, ABCB 13435C greater than T, modestly increase plasma dabigatran exposure, AUC plus 12%, but do not independently predict dyspepsia. Clinical presentation. Dyspepsia associated with dabigatran typically presents within 2-4 weeks of initiation. In the RELY cohort, N equals 18,113, the most common symptoms were epigastric pain, 78% of dyspeptic patients, early satiety, 65%, and heartburn, 57%. Nausea occurs in 34% and vomiting in 12% of affected individuals. Atypical presentations include dysphagia, 8%, and belching, 15%. Elderly patients, greater than or equal to 75 years, report higher rates of early satiety, 71% versus 58% in younger adults, P equals 0.02, and are more likely to have overlapping functional dyspepsia, RR 1.3, 95% CI 1.11.5. Diabetic patients have a 1.4-fold increased prevalence of epigastric pain, P equals 0.04, possibly due to autonomic neuropathy. Immunocompromised patients, e.g., solid organ transplant recipients, demonstrate a higher incidence of ulceration, 4% versus 1% in immunocompetent, P equals 0.01. Key points: unexplained weight loss greater than 5% in 6 months, positive predictive value 0.68. Persistent vomiting greater than 3 days, ppv 0.55. Gastrointestinal bleeding, melena or hematemesis, ppv 0.92. New onset anemia, HB less than 10 g/dl, ppv 0.81. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. Initial evaluation includes a detailed medication history, focusing on dabigatran dose, timing, and concomitant GI irritants. Laboratory workup key points: complete blood count, CBC hemoglobin less than 10 g/dl suggests occult bleeding, sensitivity 0.71, specificity 0.89. Serum creatinine and estimated glomerular filtration rate, eGFR, using CKD-EPI equation, CRCL less than 30 ml per minute contraindicates dabigatran. Coagulation profile, dilute thrombin time, DTT, normal range 1420 seconds, dabigatran prolongs DTT greater than 30 seconds, sensitivity 0.96, specificity 0.85. Eccrine clotting time, ECT normal 3045 seconds, values greater than 70 seconds indicate therapeutic dabigatran levels, specificity 0.92. Management and treatment. Patients presenting with severe GI bleeding while on dabigatran require immediate hemodynamic stabilization. If life-threatening bleeding is confirmed, administer Idarucizumab 5G4, 2.5 G boluses less than or equal to 5 minutes apart, per our reverse AD protocol. Monitor DTT and ECT 15 minutes post-infusion. Repeat dosing is not recommended unless rebound dabigatran levels greater than 30 nanograms per milliliter are documented. Key points: position supine, apply pressure if external source. Initiate 2 large bore 4 lines, Administer isotonic crystalloid bolus 20 ml per kilogram, max 2L, followed by blood products to maintain systolic BP greater than or equal to 90 mm of mercury and hemoglobin greater than or equal to 9G/dL. Continuous cardiac monitoring and pulse oximetry. Obtain baseline labs, CBC, CMP, coagulation panel, dabigatran level if available. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.